Hi, my name's Claire Owen. I'm a director here at the Medical Schools Council, and with me today I have an excellent panel who I'm just going to introduce you to. Next slide. Brilliant. So this webinar is for students sitting the AKT in 25-26. We will record this webinar and it will be available on the MSc YouTube channel. So if there's anything you want to go back and check, or if you want to share it with your peers, it will be available there. As I said, we've got a great panel. So we have Dr. Rachel Westacott from the University of Birmingham, who is responsible for the groups that write the questions for the AKT. Then we have Professor Neil Kennedy from Queen's University Belfast, and he's responsible for the policies that underpin this exam, and Professor Amir Sam from Imperial, who is responsible for putting these exams together. And we also are joined by Professor Suzanne Chamberlain from the General Medical Council, who's just going to give us a brief talk about how this webinar this exam fits into their work. Okay, so I'm going to hand over to Suzanne, who's just going to have a quick talk about the AKT from the GMC point of view.
So I'm Suzanne, I'm part of the team that's responsible for the quality assurance and quality improvement monitoring of all medical schools and postgraduate training organisations across the 4 nations. As part of the quality assurance of medical schools, the GMC sets the requirements for the 2 components of the medical licensing assessment, the applied knowledge test, the AKT, which you're hearing about today, and the clinical and professional skills assessment, the CPSA. Our role is to monitor compliance with those requirements across all the providers of the MLA. The GMC is also responsible for the delivery of the MLA to doctors who qualified overseas and who are seeking a license to practice medicine in the UK through an examination route. So as you'll know, all medical students now take the MLA as part of the medical degree, and it's an important milestone in your journey to becoming a doctor. You need to pass the MLA as part of your degree before you can apply to us to join the medical register. Having to pass the MLA as part of your degree means that when you move into the foundation programme, we, the GMC, but also your employers, your colleagues and patients can all be assured that you have the essential knowledge, skills and behaviours expected of new doctors. You can find more about the purpose of the MLA and those requirements I mentioned on our web pages. Just search for GMC MLA. As you'll hear later in this session, your degree course is the best form of preparation for the MLA. You don't need to buy any third-party revision materials. And your schools are your points of contact for more information and practice materials that you may need. So just to recap on this very brief session, the MLA comprises the 2 components, and you need to pass both of those components as part of your degree before you can join the medical register. Your degree is the best preparation for the MLA, and your schools are your main points of contact. Thanks very much. I'm now handing over to the next speaker, and I hope you enjoy the rest of the webinar.
Okay, so Neil Kennedy is going to take it from here.
Great, thanks very much, and welcome everybody. Famida, if you could just pass on then to slide 8 for me. So, and as we mentioned, the medical schools are working together to deliver the AKT, and you will be supported throughout your preparation for the MLA by your own medical schools. So what does the assessment begin to look like? So next slide there, please. So the exam is going to be delivered via the MSc Assessment Alliance exam platform. It's something called ExamRight. You may already have been using this. Many medical schools are. They use it already for their platform for other assessments throughout other years of the course. Certainly by the time that you get to take the AKT, you will be familiar with using ExamRight. And we've found it to be a very helpful platform and one that students have found very useful. Next slide, please. How do you get registered, or the device you use? Well, the medical school that you're attending is responsible for registering students. It's also responsible for ensuring that you get the right venue, and also making sure that you understand the local university exam conditions that may be in place around your medical school. Some medical schools will require you to take the MS AKT on a desktop in an IT suite for an IT lab within your university. Other universities may allow a device that they give you to bring along to the exam. But whatever way they do that, they will mandate some form of lockdown software for use through the exam. And your medical school will tell you how to use that lockdown software and how to access it and make sure that you are using it all times throughout the exam. It's absolutely compulsory for you to sit the exam using the lockdown software. Next slide, please. What's the exam look like? Well, it's a single exam comprised as two 100-item papers. It's sat over 2 consecutive days, and a successful sit includes sitting on both days. So you aren't able to sit one part of the exam in one time and one part of the second paper in another sitting. You have to sit them both within the same 2-day window. All the questions are written in the single best answer format with 5 answer options, and it's not negatively marked. The standard time for each paper is 2 hours, but additional adjustments are available for students with approved reasonable adjustments, and that is approved through your medical school. We'll come back to that later. And all of the content in the exam is aligned with the GMC's MLA content map, which you should be able to access. The next slide, please. So how are the papers arranged? Well, they're arranged in 2 areas of clinical practice. You see paper 1 and paper 2. Paper 1, 100 items over 2 hours, and paper 2, 100 items over 2 hours. And I won't go through each of these. You can see it there, and it's also available within the website. But just to point out, for example, let's deal with paper 1. And if you look at the sort of the left-hand element, you'll see there's 50 items which cover cardiovascular, respiratory, gastrointestinal, and medicine of an older child. Now, if you look very carefully, you'll see that there are 10 questions for cardiovascular, 10 for respiratory, 10 for GI, and 10 for medicine of the older adult. However, that only adds up to 40. So where do the other 10 questions come from? Well, the other 10 questions in that little lozenge will come from those 4 areas. So it could mean that there could be additional questions in cardiovascular or respiratory or GI medicine above and beyond the 10. If you look to the next lozenge along, you'll see that there's 8 for neurosciences, 2 for ophthalmology, 8 for endocrinology, etc., etc. Same rules apply. They add up there to 40, and that does mean that there are additional questions within that lozenge available for those disciplines. So there could be way more than just 2 questions set for ophthalmology. There could be 6, there could be 7. It can go like that. So it's important for you not to look at this list and think, oh, I shouldn't revise that area because there's only 1 or 2 questions about that area. That's a strategy we wouldn't think is very helpful, and you need to cover all of these different areas as you revise. Please note that general practice, acute medicine, surgery, and clinical imaging are covered right across the 4 clusters, the 4 areas of the exam. Next slide, please. So as Suzanne was saying, how do you prepare for this best? Well, the best way is go to a UK medical school and turn up on placement and study and read as your medical school would encourage you to do. That was surely the best preparation for the AKT. There are practice exams available on the MSc website, and I'll come back to that later, along with some smaller sets of practice items. And if you have comments about that, please do get in contact with your medical school. I want to emphasize that you do not need private paid courses or books. Beware anybody who tells you that they have the answer to the AKT or that they are have inside knowledge into the AKT. That just does not exist. Those who are involved in setting up this exam are prohibited to actually take part in external courses. So it is important for you to recognize that the best preparation comes from actually taking part in your medical school course and turning up on placement and getting involved in seeing lots of patients on a day-to-day basis and reading about them. MS AKT resources will always be free, and they're available on the MSc website. Next slide, please. Again, just beware websites claiming to have the AKT practice questions. None of us are contributing to them, and we can't guarantee whether they are offering the correct answers or the correct means of working out the right answers. So please do be careful. Don't be drawn in by a desire to think you can gain a few extra marks from taking part in a course which may or may not have the credibility that you'd wish it to have. Next slide, please. So what about the sub-policies? There's a national policy framework that's been developed in conjunction with all medical schools across the UK to help us guide it. Now, all of the policies relating to the AKT have been put in place to facilitate a national assessment, but there are inevitably some differences between universities. For example, I've already mentioned one, that some will allow you to sit the exam holding an iPad that the university will have given you. Others will require you to sit in front of a computer that is logged in on a hardwired connection. There are some other minor variations like that across the piece. Next slide, please. Individual medical schools choose when you will sit the AKT. Some schools sit the AKT in the preliminary year and at the end of their fourth year, or the preliminary year before they graduate. Other schools will sit it during their final year, and they take a selection of dates from a series of windows that are offered across the year, and they fit those assessment dates into the calendar that works best for their university. Your school will tell you when you will be doing the exam, and they will also let you know when the resit opportunities exist as well. Next slide, please. How many attempts are you allowed at the exam? Well, the total number of attempts is set by your university, and you should ask them, if you don't already know, what the total number of attempts available would be. But it's important to note that it's only possible to sit the AKT twice in any one academic year. So there are only 2 sittings available for any student in any one academic year. Next slide, please. What about reasonable adjustments? Well, the responsibility for reviewing reasonable adjustments lies with your medical school and will follow the policies that apply within your medical school. MSc will accept those decisions made by your medical school. We don't have rules which sort of say you aren't allowed that amount of time, etc. And as long as they can be accommodated within the assessment structure, and we found that medical schools have been able to do a wide range of reasonable adjustments through the system that we have. The platform that we use is designed to accommodate a broad range of reasonable adjustments, additional time or rest breaks, and particularly that the text functions have been very, very well received. Students can manipulate the text, they can manipulate the fonts, they can manipulate the colors, etc. And that has been found to be very helpful by most students. We've had some good feedback on what it's like to do the exam on the ExamRight platform. Next slide, please. What about mitigating circumstances? These are sometimes called exceptional circumstances, depends on what your university uses as a terminology for that. We are again working together to align our policies on that. It's important to note at the minute that the rules which apply mitigating circumstances or exceptional circumstances are the rules which apply within your university. And again, so if you're unsure of those, please do clarify that with your education leads. They will let you know what your policies are. If a mitigating circumstances are supported or applied, so exceptional circumstances are supported or applied in a university, then that attempt will not count towards a student permitted number of attempts. Next slide, please. What about the results? Well, it's a pass-fail assessment. The Medical Schools Council won't be using the scores from the MS-AKT for national ranking purposes. You will get your mark. The medical school may choose to use the scores of its students to award prizes and honours, but that's up to your individual medical school whether it chooses to do that or not. And again, you should seek your local policy for that. The next slide, please. So EDI data. We're very keen to explore EDI within the assessment and look at its effects on assessment. And so we're asking all students to complete an equality, diversity, inclusion monitoring form. You don't have to do it, but we've had a really good uptake. We're really encouraged by the number of students who've opted to do this. Within each of the questions which is in that little questionnaire, you'll have the opportunity to say, prefer not to say, for any particular aspect of information. That will be important evidence. We want to make sure that the assessment is fair to all students, especially those who share protected characteristics. And the scale of this examination allows us to really look at that in some detail. So we would encourage you to do that, please. It's only it takes a few minutes. Either some universities do it either before the exam, and I think Claire, you can nod if that's correct. Sometimes it's a little bit afterwards as well. That's right. Yeah. Please be absolutely sure that data is kept anonymous. It doesn't have any effect or bearing whatsoever on your exam results. It's only ever reported as aggregate reports. And as I say, because of the scale of this examination, we can actually aggregate large data sets to have some meaningful information within this area. Next slide, please. What resources are available to you? Well, I've mentioned already, patients, turning up and seeing patients on the ward or in clinic or in outpatients or in your general practice. Absolutely the best place for you to learn medicine. I'm sure all of your tutors have said to you in whatever medical school you go to. You'll need to read around those patients as well. But there are some other things you can look at. You can look at the MS AKT Student Handbook. It gives you some of the same information we've said today. There's some practice materials available on the website, a 200-item exam, and then also smaller sets of practice items in a PDF format with answers that you can look at. And we'd encourage you to look at those without the answers and then to look back at them afterwards with the answers. And remember, each of those questions you can use multiple ways. You can actually say, well, what would if they're writing this question not just about with the correct answer of myocardial infarction? Let's say they're also writing the question with the correct answer of pulmonary embolism. What would it look like instead? So you can use these questions in multiple ways. These webinars are recorded and you can have a look at them. And then obviously the MLA content map is available for you as well, both the conditions and the presentations, which give you a wide idea of the types of questions that we're going to be covering. A new content map is going to be published in autumn 2025 is our understanding, but I want to assure you that will not apply until 2026-27. So the content map that you see on the MS AKT website within the MSc at the minute is the one which is current for you for this academic year. Next slide, please. I think that's all from me, other to say good luck, wish you really well in the exam, and hand back to Claire, who's taking the questions for us.
I am, yeah, and we've had a really popular question around some of the different practice question banks that QuizMed and PassMed. Now, MSc would never endorse any particular platform, and none of the people involved in the AKT will be writing example questions for that. But I thought maybe, Amir, you could give us some reflections on how best to prepare for this exam.
Thank you very much. So my own students often comment that the questions that they see in the practice papers are quite different to the questions that they see in the commercial banks. Obviously, any resource, any preparation is good, but it's important to note that, as Professor Kennedy mentioned, those who are involved in the development and construction of the exam do not take part in any of these commercial activities. And therefore, the questions that are provided to students through these banks are often, from my experience, quite different to the ones that appear in the exam. And sometimes the students are quite surprised because they enter the exam expecting to see the sort of question that you see in some of the banks mentioned. And my advice would be really to look at the exam preparation material that the Medical Schools Council has provided, because these questions are taken directly from the bank that is used for setting the exam.
Fantastic, good advice there, Amir. Rachel, a couple of quick ones on what constitutes a pass on this exam. Do you have to pass both papers, or are the scores of each paper combined towards the pass mark?
The scores of both papers are combined to are combined to give you a pass mark. So that said, I wouldn't game it to think, well, I quite like cardiology, but I really don't like child health. In that, generally speaking, those that do well because they cover across the board. And again, this comes back to a previous comment. There are some things, what do you tag a question as? So some things like infection could occur in a child or an adult, and so cross boundaries to some extent. But no, it's a combined mark. So hopefully that's reassuring.
Yes, and if a student was to take the first exam, so day one exam, and was not able to take day two, would they be able to, when they did their, resit, could they just take paper two, or do you have to take two papers to get a pass? Does that make sense?
Is that still for me to answer?
Yes, yes, sorry.
That's fine. You have to sit both of the papers within the same sit. So unfortunately, if you sit one paper and then don't sit the other paper, you will need to resit on another date.
Yeah. And Neil, is extra time available for this exam? And if so, how much if students are eligible for it?
Sure. Extra time is available, and we have a large number of students who do avail of that opportunity. The rules for that are set by your own medical school. So it's whatever they come back and tell us, and you will probably already be availing of such opportunity throughout your other exams you've had in your medical school. So the process that you follow for that is through your own medical school. Then they then register that with us, so we know how much time you have available, and your exam right platform will be set up to allow you to do that. So it will tell you this is how much extra time you have got. Some universities, in fact, I think most universities tend to cohort students with a particular time equivalence in a certain area. Not universal that, but most tend to do that. So you often find yourself in the correct area or the correct room with colleagues who are around giving the amount of time. We do not have a specified limit on the amount of additional time that would be available, or rest breaks, etc. That is set by your university, and we work with that university to deliver what they have through their own policies determined to be your reasonable adjustment.
Fantastic. Thanks, Neil. Amir, you have been doing a bit of work with GMC, and so has Rachel actually, on the content map. So there's a bit of confusion because we've mentioned a new content map, but students should be looking at the one that's on there, not the new one, shouldn't they?
Absolutely. The exam is still aligned with the content map that you were introduced to and have been using, hopefully, from the outset. The new content map will be used to set the exams in future diets. So this current exam you'll be sitting aligns with the content map that was published previously and not the one that is being revised.
And I don't know if Amir or Rachel want to talk through some of the changes. We've been asked what are the changes between the two maps. Obviously, they don't really apply to students sitting the exam, but does anyone have a headline on those?
So as you know, the exam assesses your ability to make a diagnosis, to suggest steps in the management plan and aspects of the underlying medical laboratory sciences. And the questions may be framed around presentations that you see in the content map, such as breathlessness, chest pain, etc., or conditions that may be causing those presentations. And I have heard feedback from students saying that there are some common conditions that we often learn about already in our curricula, which are not in the content map. So in the new version, those conditions which are already being taught and assessed are more clearly articulated. And from experience, I don't think you will see anything that is going to be surprising. So all the things that are in the new map, in the new content map, are already part of curricula in the UK, but articulated more clearly in the list. And in fact, I think the GMC will use words like, it's an indicative list or non-exhaustive, because you can never have an exhaustive list of conditions going forward. But I assure you, the exam is really set at the level that you would expect an F1. This is not a specialty exam. This is not an MRCP or MRCS exam. And therefore, the questions that are assessing your ability to make a diagnosis or offer a management plan are set at the level that is required from a foundation year 1 doctor.
Rachel, anything to add to that, or is that okay from your perspective?
Everything that Professor Sam said is absolutely true. I guess what I would try and reassure people is there's always concern that there's suddenly going to be a whole lot of stuff that you haven't learned and that is suddenly going to surprise you and suddenly going to catch you out. And that isn't the case. And from what Professor Sam has said, it's effectively what you've learned already is going to be what is being assessed in the exam. We've all been running medical schools for a long time and have a good idea and talk to each other about the sorts of things that an undergraduate needs. So as articulated, it won't be surprising. The things that are written as words on one document and not the other are almost certainly being covered by your medical school anyway. So don't panic, would be my
Always very good advice. And Neil, do you want to come in?
Sure, absolutely concur with do not panic. It's always a good advice. I think to assure folk that an enormous number of doctors who are involved in setting the questions for this exam, they are jobbing doctors. They are people who are actually doing the rules in primary care and in secondary care in a wide range of disciplines. And one of the sort of bars that we set for the exams is this the sort of thing that would turn up in clinical practice, in regular clinical practice that you would expect somebody as an F1 doctor to know about? That's what we're thinking about as we're putting these exam questions together. So I think that maybe gives you perhaps a reassurance, you know, that these are going to be examining the sorts of conditions and the sorts of presentations that would occur in the clinic or in the emergency room or in primary care that you would be expected to have seen or to know about because they're just part of your standard clinical practice and placements within your medical school. So again, it just comes back to this idea: the more time you are involved in placement, the more time you are seeing patients, then the more likely you are to be able to apply the knowledge from those settings into the AKT exam.
And Neil, before I move on to Amir, can I just ask you a question, follow up on the content map changes, because I think you might be one of these schools where you sit the AKT in 1 year and the CPSA the following year. You would stick with the same content map for the CPSA?
Correct. Yeah.
Brilliant. Thank you. Amir.
Thank you. So we're all trying to reassure you, and you might be asking, well, what's the evidence? How do you substantiate these claims? And I'll tell you, the evidence really is if you look at how the schools performed in the first diet of the MLA, that there was no difference. The vast majority passed as they would normally, and there was no difference in my own students, you know, 350, they've sat the exams. No one said this is different to what they normally would have sat. So the exams obviously quality assured, is of very high quality because there's a lot of input from various medical schools into this. So it's a really a world-class finals exam. But as far as you're concerned, I think you won't notice any difference compared to the previous cohorts, and you can see how the previous cohort have done really well, and I think you will have similar experience.
Okay, so I've got one that's had a lot of thumbs up, so people are really, really keen for an answer on this one. How do we handle recently altered guidelines, Neil?
Thanks very much. This is a sort of an old chestnut, really. So I think there's two things to first of all to think about. We obviously set the exam. The exams are set for a year in advance. So we're setting the questions, we're establishing the questions over a couple of years, getting them ready, and then they're input into the bank, and then we're selected, and those are the questions which are going to be in place for that coming year. We have to do that because it takes time to do so. Then the other side of the piece is there's the government, etc. Professional bodies are setting guidance, and they're setting that on a continual basis. We cannot expect national bodies to set their guidance in a way which lines up with our exam. It's obviously much more important that the guidance comes first. So that situation has always existed within any medical school, and all medical schools will already been aware of that when they're thinking about how to set examination questions. The second thing is that doesn't mean just because guidance may change that it would be unreasonable to ask questions of that guidance document, because they may be very common areas of practice such as pneumothorax or diabetes, etc., which are going to come up in clinical practice. So we are aware of that as an issue. What do we do about it? Well, I think the most important thing is to say we try and make sure that no student in any way would be disadvantaged from a sudden or recent change in a guidance document, which may influence the answer of a question. So there are a number of, we are always looking out for changes in guidance, and we have a number of groups looking at particular areas where the guidance sometimes changes reasonably frequently, and specifically targeting those areas and looking for that. We also have a very robust standard setting process that exists both before the exam is set, it goes out into practice, and also afterwards as well. So we're able to examine the performance of a student in a particular question, and perhaps, you know, if there had been a change in guidance, that might reflect the way that students may answer that. So I'd like to reassure you really that we are doing our best to avoid any disadvantage on that. Obviously, the best advice is look at the most recent guidance that's available within a particular domain. But I hope that you understand that we will never be able to say that we will ever be able to use guidance from a particular time from 2 or 3 years ago, for example, because that may not be the most relevant guidance that you would be required to answer a question about.
Amir.
Thank you. No, I would like to echo what Professor Kennedy has just said, but also from a practical point of view, this assessment is assessing your knowledge at the level of an F1. And the questions are asking the fundamental principles. And that's, again, some of the differences between this exam and some of the commercial banks, where they ask, you know, very detailed questions. You know, what's the third line management of a patient in diabetes? That's for a diabetes consultant or a senior registrar to be debating, not for an F1. You don't ask an F1 to come in and make a decision after the patient has been on 3 different treatments and then you want to escalate further. So learning about the principles is important, and those principles often take a long time to have a paradigm shift. So you can be confident that if you've learned the fundamental principles of managing pneumothorax or diabetes, they will still apply. And in the unusual occasion where we think actually a change in the guidance has had an impact on a particular question, the principle, again, will be, as Professor Kennedy said, a no detriment. So those students who have not had a chance to look at the latest guidelines, because we recognize it also takes time for guidance to be implemented. Even NICE says there is a time period during which we expect the guidelines to come into practice. And therefore, you won't be disadvantaged. So we don't want the students to be stressed close to the exam and trying to look up all sorts of guidelines, see what has changed and what hasn't changed. Obviously, as part of your revision, you look at the most up-to-date things. Remember, the fundamental principles are assessed, not the minutiae detail. And in the event that that is the case, we will always look at the assessments questions and do a post hoc analysis. And it may be that a question may be even removed from the assessment if the need arises. That's very unusual, but I just want to reassure you that we do look to make sure you are not disadvantaged.
Rachel, do you have just a few comments, I think, to add to that?
Mine's a very short one. So we described the process by which we set up papers and the reason why that needs to be done in advance to quality assure them. It was just a very simple thing that we do look at them again. So it's not that there's a year and then no one looks at the question. So they are looked at as they are happening, so that if something has changed, it is flagged as well. Just to reassure you and then everything else everyone said.
So I've had a lot of questions about what method do we use to set the pass mark? Do we trial the questions on F1 doctors? You know, how do we do the standard setting? Who'd like to go first on standard setting? Amir, do you want to go? Yeah.
Sure. So the methodology used for standard setting the exam, the AKT, is the widely used method of modified Angoff that is used in most medical schools in the UK. And essentially the panel will be asking themselves what percentage or proportion of day 1 F1s would get this question right. And if it's a question on meningitis, the panel may agree after some debating and scoring that they expect 80% of day 1 F1s to be able to manage that. And if the question is on autoantibodies in SLE, they might think actually it's 40%. And the averages of all those scores will constitute the pass mark for the MLA.
Brilliant. And students are interested in what the pass mark has been historically, but Rachel, do you want to answer that one and also follow up on what Amir said?
So I wasn't going to give what absolute pass marks are, but they will not be way different to your medical schools, is what I would say as a general rule. We all follow the same sort of principles for all the other exams we set. I think there was also some question around whether we norm reference, and by norm reference, how students are performing, and we absolutely don't. So each paper is set looking at whether we think, as Professor Sam has described, what we think that a student will answer and how likely they are to answer. So that means that all students can pass. We don't have a paper whereby we fail 10% or we make sure that a certain number pass or fail. So it's absolutely possible that all of you can pass it. The quid pro quo is that it will never happen that all of you fail it, because that would be an issue with how we standard set it and would be a major issue, but absolutely all of you can pass.
Just a really quick one that I was going to follow up on. Do students receive a breakdown of their marks, Neil?
So you'll be given your mark out of 200. You'll get a mark and you'll be told what that mark is. You'll get an idea of the domains and how you've performed in the different domains. You obviously do not get a question by question feedback. That would be challenging, because it would obviously mean that we are never able to use questions again in the large bank of questions that we have. And the amount of effort, the time that goes into making these questions is considerable. So we want to make sure that we can reuse really good questions in further years. So yeah, you do get a domain area feedback, but not specifically for each question.
And then Rachel, I've got one about the questions, and it says, will there be references to older psychiatric diagnostic manuals? Diagnoses are quite different with different names and key to answering certain questions.
That's a very good question, and one that has been debated at length. So we have gone through all of the psychiatry questions. We do use up-to-date evidence, but we are also conscious where some of the controversies arise, particularly with the new DSM and ICD categorization that's happened. So we try and avoid the controversies, is what I would say. And this comes back to the idea of disadvantage. So if you did your psychiatry 2-3 years ago, it would be unfair for us to make you go back and do all of your psychiatry again. And again, this alludes to what Professor Sam has already said, that it's around principles. So the short answer is, don't feel that you have to go and learn ICD-11, DSM-5. You don't. The questions will be written in a way that is fair and allow you to answer them correctly.
I've got a question here about NICE guidelines and differences between Scotland and England. Rachel, would you like to cover that one again? Because you do the questions, don't you?
Sure. Again, good question. Where there is a difference, we either don't ask, well, we don't ask the question. If you couldn't answer the question in the same way in any of the 4 countries, that question doesn't become part of the exam. Schools may use those for their individual questions, and that is fine, but they won't be part of the AKT exam.
And as the Celtic Fringe representative on the panel here, I'll endorse that. We're always looking for that 4-nation specificity, because it's really important that we don't ask a question which would be, the answer would look different in different parts of the country.
So I think there are some questions around what I would describe is, how is this exam made up? So there's a question, how much freedom are medical schools given in choosing their questions? And also, does everybody sit the same paper? So, Amir, would you like to answer that one?
Thank you. So medical schools do not select the questions. The papers are set nationally, Medical schools contribute, so all medical schools are involved at various stages of constructing the exam, developing the items, setting the standards, contributing to the policy. But at the level of constructing the exam, it is not set or selected by the individual schools. It's centrally set. There is a different paper for different diets. So if you're sitting the paper in the January, all the schools that are sitting the paper on that day will have exactly the same paper. And there are restrictions around quarantine, etc. So there's no leakage. Everybody does it at the same time. And a different diet, there'll be a different paper. But again, every school that sits the paper on that day will have the same paper, so that there is fairness and there is no opportunity for any of the schools to select or influence the paper at the level of construction.
Would anyone like to add that? I've got one saying, does the exam get harder the later in the year that you take it? Rachel.
Absolutely not. So the papers are all generated separately, but then when it comes to things like standard setting and reviewing them, that is done as one process. So they are equivalent. And that part of the reason for standard setting is that you should be equally likely with the same. If you sat the exam, it shouldn't matter whether you sit it in November, January, May. If you're equally well prepared, you should pass the exam or get similar score, regardless of which diet you sit it in.
And the same holds for the preliminary year schools versus the final year schools as well. The standard is the same.
Absolutely. So I have a very technical question about the secure exam browser and whether it stays on people's computers. But what I would like to say is that very few people take this exam on their own computer. I'm going to answer this one for you. So very few people take this on their own computer. They may take it on a computer that their university has gifted to them for, Amir, I think that's the case at Imperial. If you are at all concerned about it, the whole thing is set up locally by your medical school and their IT teams. No one on this call, unfortunately, is a technical advisor for IT, but I would advise you to talk to your medical school. It is we want to be incredibly reasonable. We don't want you to have programs on your computer that you don't need to be there, but your medical school will be able to tell you how to put it on and how to take it off as well. So there are lots of questions, lots of people would like to know. So they're saying that maybe MSc, the practice papers that MSc puts out are very helpful, but if students wanted to find more material to practice on, what should they do? Or I'm going to add a coda to this. What would be the alternative to practicing questions to prepare for this exam? Amir?
Thank you. So in terms of preparation, you could do one paper a month from the material. You could do August, September, October, November, December, January. There is a paper for every month of the year. And then there is the big paper, the 200 item, which could give you a flavor of what the whole thing looks like. And then there is another paper that has specific specialties in there: obs and gynae, peds, psych, and child health, women's health, and mental health. So there is a lot of preparation in terms of getting used to what the questions look like, and also familiarizing yourself with the platform, because you have the opportunity to sit these exams on ExamRite through your medical school. So you are comfortable with how the platform works, whether you're doing it on iPads like our medical school or on computers like other schools. You have the opportunity. Beyond that, really, my personal advice would be experiential learning. Spend as much time as you can talking to patients, because a lot of these questions, unlike the questions you see in the banks that are very telegraphic, you have an ejection systolic murmur in the aortic area, what is it? These are not the sort of questions that you see. Our exams are: the patient presents, this is their history, these are some of the blood results, examination, etc. How do you put them together? And that's what happens in the workplace. The best place to learn about the diagnosis and management of these conditions is on the wards in clinics.
Neil, would you like to follow up to that? I've also got a question saying, is there anything you would not recommend for studying that students tend to use?
Gosh, Wikipedia, I guess that would probably be a no from me. There's a wide range of good textbooks out there. You know, I personally am a fan of the sort of I probably get sued now by the makers of alternative books, but like MacLeod's methods or Hutchinson's methods, those diagnostic type books, those are really useful, I think, for people looking at final years types of questions. So books which cover differential diagnoses for presentations, that's helpful. It's the common textbooks, I think, are the ones that, and your medical school will be directing you to high quality resources that will be available for you. I would follow their advice. Okay. I have to say I like a book. It's amazing. I find so many students of my own in Belfast are unsure about what a book is and perhaps use other things instead. But books are great, and there are some fantastic books out there that will give you lists of potential courses of presentations, etc., that will help you to develop your own algorithms and understand in your own head the old clinical reasoning algorithms that will help you to get to the right answers. So use the books that your medical school suggests you should do would be probably my best, rather than avoid the following book.
Absolutely. Rachel, you want to follow up on that?
Yes, the one thing I would say is that having worked in medical schools for a long time and with students for a long time, one of the things that tends sometimes to separate students that do well from students that struggle slightly more is whether or not they're actually understanding stuff. So one of the problems with just using, and I think using past questions and looking at questions can be helpful, but if you're using them just to remember the answers to the questions but don't understand the rationale for why, then if a question is presented in a slightly different way or is something slightly different to the ones that you've seen before, you end up being in trouble. Whereas actually, if you don't know an answer, you go back to try and understand the answer. You make sure that you actually have a good understanding rather than a rote memorization. You're far more likely to be able to reason when you get a question that you weren't anticipating, or if it's done in a slightly different way. So my advice would be, don't rely just on trying to memorize things, but make sure that you understand, particularly around the fundamental key big topics.
Amir, did you want to add to that?
Thank you. No, I had a different point, because there seems to be some anxiety around the pass mark. So I don't think Dr. Westergaard meant to conceal or hide the pass mark from you. The nature of the standard processing is that the pass mark is entirely dependent on the difficulty of the question. So it will go up and it'll go down. And therefore, I wouldn't put much weight on what it was last year, because if the question is a bit more difficult, the pass mark will be lower, or it might be slightly higher. But it's in line with the pass marks that historically have been set at medical school levels. And all you have to look at is the outcome. The vast majority of the students have passed, and those who didn't have passed second time. So the vast majority have gone through as normally, and I wouldn't worry about it. It's a good thing that the pass mark moves up and down, because you can be assured that it is in line with the difficulty of assessment. It's not a fixed pass mark. If it's a bit more difficult, the pass mark will be lower.
Yes, exactly. Everything's done to benefit this, to make sure that this exam is as fair as possible for the students that are taking it. That's I sit in some of those discussions, and I can promise you that that is absolutely at the core of everyone's thinking. Neil.
Just to reinforce that, one of the nice feedbacks we've been given by students, student representatives nationally even, is that I think students feel that it is an even level playing field. They feel that they're all getting an exam which is the same across, and they're able to benchmark, and they feel that, yes, I've achieved something that a student in another medical school would do. That's good. But also the quality of the questions, and the quality and clarity of the questions, and the nature of them. Again, it's been recognized that seems to be really very high. And you would expect that because of the numbers of pairs of eyes which look at each question. I mean, each question is reviewed maybe 6, 7, maybe 8 times by the time it gets into the paper. So it's an incredibly robust process to make sure that these questions are extremely high quality, and we leave out extraneous words, or we try and resolve any ambiguity as much as we can before any question gets into the bank. So just to assure you that has come back from students as saying that it is a very high quality exam, and not just in terms of the level of knowledge it's set, but also in the way that it's presented.
Fantastic. Thanks, Neil. One I've missed is when are results released? Rachel, would you like to answer that one?
So there is a turnaround process that the MSc have where we make sure that the results are available to schools, but then it's for each individual school to decide when it actually releases the results to the students. So the best way to find out for your individual school is to liaise with your individual school's assessment team. And that's because for some, they will join it up with their CPSA exam or with other assessments. So we have a process by which we make sure that everything is available within just after 2 weeks, but then it's the medical schools decide actually when to send out the results, so it fits with individual schools' timetabling.
Fantastic. Thanks, Rachel. And something else I've missed, do you give normal reference ranges?
That's an easy one, yes.
Yes, okay. Fantastic. I have a question. I think it's to help students revise, but it is, should we focus on the core details of conditions and presentations rather than the intricate details as focused on by question banks that they're reading? So is it broad or is it very intricate? Neil?
I hit the mute button quick as I could. Breadth is absolutely the right way to go here. I would really encourage you to think particularly about presentations and as the first place, and then conditions afterwards. But getting down into the weeds, as Professor Sam was saying, what is the the third most likely useful drug in, or third series drug in treating particular type of subtype of multiple sclerosis, for example. I mean, I have no clue about that question. And, I'd be looking at it going, okay, if I've got to look that up in about 10 different guidance, just empirically, that would say, well, that sort of question shouldn't make it therefore into the exam. And all of us are looking at it in the same sort of way like that. So we are looking for questions which are going to be reasonable things that could be expected for an F1 doctor or doctor just entering practice to know about. So focus more on the breadth. And I, as I said, I think Professor Sam said this, there are some question banks which tend to be very, very deep and perhaps not as broad as we would want them to be. If you are going to use such question banks, I would definitely encourage you to say that you do some reading first, because as Dr. Westcott was saying, getting an understanding of it first, getting an appreciation of what it really means in that particular subject area. Let's say it's, I don't know, a particular aspect of child health. I'm a pediatrician, so let's say it's developmental disorders in children or developmental milestones or something like that. Read it, understand it, and then do a bunch of questions about that particular area rather than just random questions from here and there. That is a really bad way to revise. Until you get towards the very final moments, and then maybe in the last month or something before you're coming to the exam, that's when you can then use the more broad approach and using some of these other bigger exam questions or exams that we've got on available for you to highlight particular areas where you may be deficient. But it's a systematic way of approaching the broad topic areas from early on will help you.
Hey, a really quick one to Amir. Any half marks in this exam?
No.
No half marks. We have put the link in the chat to where you can find practice papers. There are 2 types of practice papers, essentially. There's the link to the one that oh, sorry, I'm going to start again. There are PDFs on our website. The other lot of papers are on the platform themselves. So you will need to be given access by your medical school to them. They are for 2 purposes. It's good to practice questions, but they're also there so that you can understand what the platform looks like. Because, the worst thing is to get onto an exam and not know, which buttons to press to move on, how it all works, all of that sort of stuff. So your medical school will definitely be giving you an opportunity to use that practice function, particularly if you don't use ExamRight at the moment. So that's why you won't find everything on our website. Some of it is in the bank, some of it's on our website. I think I've got 3 minutes left, and I'm just going to see if there's any. Oh, can we use calculators? Amir, I know you know this one. Yes.
Yes, if need, yes, absolutely. Not a scientific one, but I think simple calc. But in all honesty, you don't really need a calculator for. You
There's
need it.
there's a calculator
Yeah.
function within the ExamRight platform as well.
Yeah. So which is a
Yeah.
simple. Yeah.
I think we are pretty much done. There's some a comment, some feedback on is it possible to have clearer ECG images? And someone has said maybe they aren't always clear in the hospital either. But Rachel, do you want to answer that one quickly?
So that's interesting. The ones that are used in the AKT, I would argue, are clear. Again, this comes back to what Professor Kennedy said. They've been through about 40 pairs of eyes by the time they're used in an exam paper. There are various groups that go through, and one of the things we look at is clarity. I can't comment on some of the ECG questions that might pitch up in people's exams otherwise. But for the AKT purposes, one of the things we look at is to make sure. I accept that ECGs can look very wonky when you're on the wards, but we don't try and replicate that degree of reality when we do the exam.
Fantastic. Amir, do you want to add anything to that?
Thank you. And of course, remember, we always look at the performance and the metrics after the exam. And if we see that there's been any ambiguity, any problems with the questions, we will look at them again. There are panels that go through questions, question by question, look at it. And as I said, if the panel find that the question has been ambiguous, that there's enough information, etc., they will consider even removing that question. So I wouldn't worry in the middle of the exam if you're finding that there's a problem with the question, just move on and rest assured that we will be looking at all the questions after the exam again.
Okay, so we've got 1 minute left and I've finished my questions now. I would like to thank the students who are on this webinar hugely for some really good questions, very insightful, and I hope that you've got what you wanted out of this event, and it will be recorded and placed on our YouTube channel. You can see it's been a long hour for me, so I'm going to draw it to a close, and I'm going to thank Neil, Amir and Rachel and Suzanne from the GMC for coming and helping us today. And most importantly, I'm going to wish you the best of luck with your AKT this year. I hope it's been reassuring. I think that's what I've taken away from this, is that everyone on the panel wants you to do well. We're trying to make an exam that's fair, and that the best preparation is to follow what your medical school says and get out on the wards and see patients as well. So thank you very much, everyone.